Assalamu alaikum. This is the third part on presentations on oral ulcers. This presentation will cover chronic oral ulcers. In the previous two presentations, we covered the acute oral ulcers and the recurrent oral ulcers. In this presentation, we shall go through chronic oral ulcers that can be broadly classified into solitary or multiple ulcers. For the solitary ulcers group, they include the common traumatic ulcer and the sinister malignant ulcers, but they also include things like necrotizing sialometaplasia and eosinophilic ulcers, and a group of solitary ulcers induced by infection like syphilis, TB, cytomegalovirus, and deep fungal infections, and some granulomatosis. On the other hand, the multiple chronic oral ulcers include the very common major aphthous stomatitis and dermatology disorders, including lichen planus, Lichenoid eruption, and a group of skin disorders, the blistering dermatosis. Start with the solitary chronic oral ulcers, with the most sinister of them all, the malignant oral ulcer. 95% of all oral malignancies are ulcerative squamous cell carcinoma. They affect men more, particularly in the age group above 40 years. They have a crater-like, a rolled and indurated border and a velvety base. They can be painless to start with, but if they involve any nerves, they can cause pain or paresthesia. Other presenting symptoms may include things like earache, referred earache, of course, trismus, dysphagia, halitosis, and neck nodes. The most common site would be like this, the lateral border of the tongue. They can also affect the floor of the mouth and the lower lip. They are almost always solitary, but in rare cases they can have a multifocal presentation. Of the other less common sites and presentations include the alveolus. Here you would see a squamous cell carcinoma ulcer in a hyperkeratotic area because of an ill-fitting denture. They can also present like a fungating mass that becomes apparent after dental extraction for a loose tooth. A squamous carcinoma of the gums and the alveoli tend to occur in the molar and the premolar regions, particularly of the lower jaw. Lymph node enlargement can be seen early. In addition to squamous cell carcinoma, there are other malignant causes for oral ulcers, including the non-Hodgkin's extranodal lymphomas, the minor salivary gland tumors. Both the lymphomas and the minor salivary gland tumors commonly present as masses, but can also present as an ulcer. You can also see an extension from a tumor of the maxillary sinus into the upper alveolus, or odontogenic tumors, metastatic neoplasia of the connective tissue of the bone, and neoplasia of the melanocytes. Oral carcinoma is the most sinister of all oral ulcers, and its diagnosis has to be categorically excluded as a first step in the management of solitary chronic ulcers. There are some features that would raise suspicion of oral carcinoma and other features that may reduce this suspicion. And the suspicious groups of ulcers are the ulcers that are non-healing and painless. Solitary ulcers present for more than 2 weeks, particularly if there is induration and thickening and rolled edge. A history of smoking and alcohol would also raise the suspicion, particularly in men over the age of 40 or 50 years, and if there is a previous history of diagnosis of a pre-malignant lesions. And in addition, if there is no history of previous ulceration, this is a de novo ulcer in this age group, and when there are no local or systemic factors to explain the ulcer, like no potential cause for local ulcers or systemic conditions. On the other hand, the features that may reduce suspicion include recurrent ulcerations that heals in between the episodes. Multiple ulcers would also reduce the suspicion, particularly if they come in clusters. And if the ulcers are associated with systemic disease, particularly autoimmune disorders, and if there is a history of blistering formation or associated with gingivitis, sore and bleeding gums, and if there is an identifiable local or systemic cause, for example, a sharp tooth. Hepatic ulcers are one of the commonest causes for solitary chronic oral ulcers. They affect more the buccal mucosa. About 40% of them would occur in the buccal mucosa, followed by the tongue, the lateral border of the tongue, or the lower lip. The borders of the ulcer would usually be raised. They can be either reddish or whitish in a hyperkeratotic area. The base of the ulcer is yellowish to white and covered with a pseudomembrane that can be readily wiped off. The ulcers would usually be painful, at least for the first 3 days or so, and gradually the pain would subside and the ulcer may heal within a week or 10 days if the local cause of irritation is removed. They may persist a bit longer if the ulcer is sited over the tongue edge. Traumatic oral ulcer may enlarge or persist for several weeks if the traumatic insult continues, like a ragged tooth or an ill-fitting denture, for example, and they may get secondary infected. The management include coating the ulcer surface with a fluocinolone or triamcinolone acetonide in an emollient base after meals and before bedtime. This would relieve the pain and also decrease the duration of the healing. Another chronic oral ulcer that may be caused by trauma is the eosinophilic ulcer, termed the traumatic ulcerative granuloma with stromal eosinophilia. It affects females more in the age group between 40 and 60 years. It affects mostly the tongue, more than half of the cases, followed by the buccal mucosa and other regions like the retromolar area and the floor of the mouth or the lips. They are almost always solitary. They have a punched out appearance and the border would be rolled and surrounded by either erythema or keratosis, whitish keratosis. They are mostly asymptomatic and there is no much pain. The healing time can vary between very short, like a week or so, up to a year. The main etiology for such ulcers is not very clear, but trauma is elicited in just less than 50% of the cases. The edge of the ulcer is rolled and elevated, and this resembles very much an ulcer of squamous cell carcinoma origin. The ulcer size can range between 5 millimeters to few centimeters. In about 2/3 of the cases, the ulcer would be asymptomatic and persists for few months. And surgical excision is the recommended and accepted form of treatment to rule out malignancy and also to cure the ulceration. Recurrence is very rare. Other forms of management include intralesional steroids injection or topical steroids and antibiotics, or sometimes cryotherapy as well. Necrotizing sialometaplasia. This is probably an infarction due to ischemia of the minor salivary tissue distributed within the oral cavity. It affects more middle-aged men. The predisposing factor is usually a direct local injury, like, for example, injection with a needle in dental work, and even finger manipulation of the palate to induce vomiting in bulimic patients. It affects anywhere in the oral cavity that has some salivary tissue, but more than 75% of these ulcers would be in the palate, followed by the lower lip and retromolar area, sometimes the sublingual area as well, or even the larynx. They can be as big as 5 centimeters. The edge of the ulcer is indurated and has a crater-like type, well delineated border. They start to heal within 10 days, but they may take up to 6 or 7 weeks to heal completely. Following the predisposing factor, which is usually a sharp, direct local trauma, or an ill-fitting denture, or upper respiratory tract infection, or even radiotherapy, the initial lesion would be a tender and erythematous nodule, followed by the deep ulceration due to the necrosis and the ischemia of the salivary tissue. The ulcer would have a yellowish base. It resembles a squamous cell carcinoma because of the indurated and rolled border, and it can also resemble mucoepidermoid carcinoma. And if the ulcer persists without healing for a few weeks, it should be biopsied. Now move to a group of solitary chronic ulcers caused by infections, started with the tuberculous oral ulcer. The WHO estimates that TB is still around in the area of several million cases. 1.4% of these cases would have oral ulcers. They affect males more. They are almost always solitary and affect mostly the tongue, followed by the gingiva, but they may affect the floor of the mouth, the palate, the lips, or the buccal mucosa. The characteristic feature is this: the rolled undermined border. This undermined border may be ragged and is often painful. The differential diagnoses include things like traumatic ulcer, syphilitic ulcer, or squamous cell carcinoma ulcer. All are solitary chronic oral ulcers. Syphilis can cause an oral ulceration, the chancre. It's a solitary chronic ulcer caused by the Treponema pallidum about 1 to 3 weeks after the acquisition. It's usually on the lips, particularly the upper lip in males and the lower lip in females, but it can also affect the tongue or the pharynx or even the tonsils. The base of the ulcer is clean and it is red, purple, or brown. The edges are ragged and rolled, and there is usually cervical lymph nodes. Again, the differential diagnoses include things like traumatic ulcers and squamous cell carcinoma ulcers. 80% of the adults would have serological evidence of a previous cytomegalovirus infection. This is usually asymptomatic, but it's in the immunocompromised patients who are receiving immunosuppression or HIV positive patients that manifestations of the infection may be noted. These can be general, like fever or myalgia and lymph nodes in the neck, and also oral ulcerations. The oral ulcers are usually large. They affect the keratinized and the non-keratinized areas, particularly of the palate and also the lips. They are painful and shallow ulcers with minimal rolling of the edge. The base of the ulcer is usually covered by a necrotic slough. The cytomegalovirus may be persistent for a few weeks or few months. The ulcer would heal very slowly. It's usually treated by antiviral agents plus a topical anesthetic and systemic analgesia due to the painful ulcer. And move to oral ulcers caused by a group of fungal infections, deep fungal ulceration, including histoplasmosis, blastomycosis, and mucormycosis. For the first two, there is usually a history of lung disease or dealing with animals. In mucormycosis, there is usually a debilitating disorder such as diabetes or immunocompromised subjects. In the histoplasmosis, there is usually an area of erythema that converts into a granulomatous ulcer, a sort of an ulcer with evidence of granulation tissue around it, warty-like type of ulcer. This is usually associated with pulmonary involvement and can also occur in the disseminated form of the histoplasmosis. The other deep fungal oral ulceration is caused by blastomycosis. It affects men more and can affect any area in the oral cavity, and it's usually a solitary, painless ulcer with irregular and rolled border. It has the appearance of a verrucous mucosal hyperplasia. This is the most frequent feature. A verrucous ulcer with indurated border that's often mistaken for oral squamous cell carcinoma. It usually occurs concomitant with pulmonary lesions, and as seen here in this chest X-ray. Third type of deep fungal infection is the oral mucormycosis ulcers. These would usually affect the palate. They are solitary, large, and deep necrotic ulcer due to invasion of the palatal vessels. They start like a verrucous ulcer, but they have a necrotic appearance as well because of the ischemia induced by the vessel invasion. It's usually concomitant with a pulmonary disease and have an underlying debilitating disorder like diabetes or immunocompromised subjects. There is a group of granulomatosis causing solitary chronic oral ulcers, starting with the granulomatosis with polyangitis, previously termed the Wegner's granulomatosis. The pathology here is a necrotizing vasculitis plus a granulomatous inflammation. They present as an oral ulcer associated with disorders of the upper respiratory tract infection. The lungs and also the kidneys are involved. The initial lesion would be a painful cobblestone change to the mucosa of the palate. In advanced case, this would cause a palatal perforation like in here. The diagnosis would be established with C-ANCA and P-ANCA, but their absence does not necessarily rule out the diagnosis. The treatment is corticosteroids plus cyclophosphamide. The other granulomatosis that can cause a solitary chronic oral ulcer is sarcoidosis. This can give rise to a single superficial ulcer, sometimes combined with nodules and swelling of the buccal mucosa. We move now to multiple chronic oral ulcers, starting with the very common, the major aphthous stomatitis, and then the group of skin conditions. The common one of them is the oral lichen planus and the lichenoid eruption as a hypersensitivity to certain agents and medications, followed by the blistering dermatosis, the Pemphigus vulgaris, the mucous membrane pemphigoid, the bullous pemphigoid, and the linear IgA disease, and finally the angina bullosa haemorrhagica. With the major aphthous stomatitis. In fact, the majority of chronic oral ulcers are accounted for by the major aphthous ulcers. They are different from the much commoner minor aphthous ulceration in that they can affect keratinized and non-keratinized areas like the dorsum of the tongue or the palate and other sites in the oral cavity. They are also larger and deeper than the minor aphthy. They persist longer, sometimes over 6 weeks, and can leave scar tissue after healing. They can also cause substantial pain and sometimes fever, dysphagia, and malaise. The treatment for aphthous ulcers is best initiated as early as possible. The ulcers may be covered with steroid pastes, things like 0.1% triamcinolone acetonide. It's best to dry up the mucosa around the ulcer before the application of the paste so as to allow it to adhere to the mucosa. Antimicrobial mouthwashes like chlorhexidine, povidone iodine, or benzidamine can also help in preventing secondary bacterial infection. Major aphthous ulcers seen in conditions like, for example, HIV disease may be treated by intralesional injection of triamcinolone, while the widespread resistant disease, corticosteroids systemically can be tried, perhaps coupled with steroid-sparing drugs like azathioprine. Other medications, including colchicine, dapsone, pentoxifylline, have also been used in the management with varying success rates. The most common skin disorder to have oral manifestations is the lichen planus. It's a chronic autoimmune mucocutaneous disease that affects females more, particularly the middle-aged. And the prevalence is quite high, and the oral lichen planus could be seen in as much as 2% of all the cases of lichen planus. They have different subtypes with different clinical presentations. Different subtypes of the lichen planus has different clinical presentations. The most common is the reticular form with the characteristic Wickham's stria on the buccal mucosa or the tongue, and it's generally asymptomatic. There is also the atrophic form affecting the gingiva and giving rise to desquamative gingivitis. Then the plaque form, this resembles very much hyperkeratosis on the dorsum of the tongue and is more common in smokers. And the erosive or the ulcerative form, characterized by a large map-like lesion on the ventral surface of the tongue, surrounded by a hyperkeratosis, and can be quite painful. Lichen planus is considered a pre-malignant lesion. The risk of malignancy can be as high as 3.7% and can often develop even after 10 years or so. The most frequent sites affected is the buccal mucosa, followed by the tongue, sometimes the gingiva, the palate, and the vermilion border. Pathologically, the lesion would show hyperkeratosis, but also degeneration of the basal cell layer of the epithelium and the presence of subepithelial band of lymphocytes, the so-called interface mucositis. The demonstration of fibrinogen deposition beneath the basement membrane by direct immunofluorescence is diagnostic. For the asymptomatic subtypes of the lichen planus, no treatment is required, but just a good follow-up and perhaps also prolonged follow-up. But for those patients with symptoms like the erosive type, the treatment is usually topical or even systemic corticosteroids. Lichenoid eruption is an example of a hypersensitivity reaction to certain medications. Here, the agent was a beta blocker that caused a central necrosis, but peripheral reticular, a white stria coming out from the central necrosis. The ulcer would be painful, but it would resolve completely after stopping the medication. The medications that can cause oral ulceration in the form of lichenoid eruption includes things like antimalarial drugs, antihypertensives, beta blockers, antimicrobials like tetracycline, non-steroidal anti-inflammatory drugs, aspirin and naproxen, oral hypoglycemics, and other drugs including, for example, lithium and lorazepam. And then there is the group of the blistering dermatosis, the Vesiculobullous disease, starting with the Pemphigus vulgaris. This is a chronic vesiculobullous mucocutaneous autoimmune disorder. It's acantholytic, as the circulating antibodies against the desmosome protein would lead to a loss of cell adhesion, acantholysis, and blister formation. It affects subjects in their 4th or 5th decade of life and affect mostly the buccal mucosa, the palate, or the gingivae. It gives rise to map-like shallow irregular ulcers with peripheral extensions. The ulcers keep extending. The lesion at first is a bulla with a very thin roof that easily ruptures, so it can rarely be seen, the bulla intact. The patient usually presents with the ulcer itself. They also have the characteristic positive Nikolsky sign. This basically reflects the ease by which the roof of a lesion can be sloughed off by very mild friction. Some of the patients would have desquamative gingivitis, and 50% of the patients with pemphigus vulgaris, they would have oral manifestations as their first sign of the disease. The edge of the ulcer would continue to extend over a period of weeks until they involve a large area in the oral cavity. Clinically, the patients with pemphigus vulgaris would have these large, shallow ulcers and sometimes desquamative gingivitis. The differential diagnosis would include the other forms of erosive mucosal disease, such as mucous membrane pemphigoid, erosive lichen planus, and erythema multiforme. They can be distinguished by a biopsy to identify the level of separation of the epithelium. This is an acantholytic type of lesion, and also direct immunofluorescence to localize the autoantibodies attached to the tissues in the suprabasal areas of the stratum spinosum. It can usually be treated by systemic steroids, sometimes in high doses, with the addition of steroid-sparing agents like azathioprine. Other agents have been tried as well. A maintenance dose can be monitored by the level of the pemphigus antibody in the serum. Another vesiculobullous disorder, which affects the oral cavity far more common than the pemphigus vulgaris, is the mucous membrane pemphigoid. It's a chronic blistering condition, affects the oral mucosa and also the ocular mucous membrane. It affects mainly mucous membranes in over 90% of the cases, but may also affect the skin in about 20 or 30% of the cases. It affects mostly the gingiva and the buccal mucosa and can give rise to desquamative gingivitis, like in here. It has a female predilection, particularly in the 5th and the 6th decades of life. In contrast to pemphigus vulgaris, the blisters are not as fragile as those of the pemphigus vulgaris and can sometimes the patient present with intact bullae. The lesions are mainly on the gingiva, and sometimes they can have eye lesions as well, with frequent scarring of the canthus or the cornea or the eyelashes, giving rise to entropion, and can sometimes be complicated by visual problems. The diagnosis would be established by a biopsy, which would show that the epithelial separation level would be at the basement membrane rather than intraepithelial like in pemphigus vulgaris. There is also no acantholysis like in pemphigus vulgaris. Direct immunofluorescence would show a linear distribution of the IgG and C3 localized at the basement membrane as well. Clinically, sometimes there may be blood blisters. This is sort of a characteristic feature that occurs because of bleeding into the intact bullae. The treatment is usually topical steroids, but systemic steroids may be required, particularly if there is ocular involvement. In some refractory cases, then medications like azathioprine may be added to the steroid as well. Another vesiculobullous disorder is the bullous pemphigoid, which affects patients above the age of 60 years. It's uncommon to have oral manifestation for the disorders, only in about 16% of the cases. It leaves multiple discrete vesicle formations, similar to pemphigus vulgaris lesions, but less painful and also smaller in size. It can also cause desquamative gingivitis, and it does not affect the lips as much as their affection in, for example, pemphigus vulgaris. It's self-limiting and also has early remissions. It is being reported in conjunction with other diseases like multiple sclerosis or malignancies, or with the use of certain medications, particularly diuretics. The treatment is topical steroids in the management of the localized oral lesions, but extensive lesions would require systemic steroids either alone or in combination with immunosuppressive drugs as well. Another autoimmune subepithelial mucocutaneous disease is the linear IgA dermatitis, which affects mainly females. It can affect both adults and children, with the peak incidence at the 6th or the 7th decade of life. It affects mostly the palate, hard and soft palate, tonsillar areas, and the buccal mucosa, and can also cause desquamative gingivitis. The lesions are very similar to mucous membrane pemphigoid, forming vesicles that rupture and leaves about painful ulcerations and erosions, plus the desquamative gingivitis. They are usually managed by topical steroids, but sometimes dapsone therapy for the more severe cases is recommended, or systemic corticosteroids in very resistant cases. And finally, the angina bullosa haemorrhagica. This presents with a blood-filled bullae on the soft palate or on the cheeks mucosa. The bullae arise rapidly, often as a result of minimal trauma, like eating, for example. Patients can become very alarmed with this bullae and have a choking sensation. They may rupture to drain all the blood and leave about a painful ulcer. The disease is seen more in patients who are using steroid inhalers with a poor technique, leading to deposition of high doses of steroids on the soft palate or the buccal mucosa. This would lead to mucosal atrophy and capillary fragility, and this would initiate the bleeding into the vesicles. These patients would be instructed on a better inhaler technique and asked to mouthwash and gurgle after using the steroid inhaler. By this, we come to the end of this presentation on the chronic oral ulcers. Assalamu alaikum.